have Colonel Binu Sharma, a very good friend of mine, and Kaho, who's the Vice President, Nursing Services at the Columbia Asia Group of Hospitals and has been associated with this group since 2007. She's an integral part of the hospital operations team and is also a certified NABH assessor. Prior to joining Columbia Asia, she was engaged with the Max Healthcare Group, where she was responsible for designing the nursing architecture and setting up hospitals and leading the entire nursing team. She also served the Indian Army in the capacity of nursing officer for 2 decades, handling clinical and administrative responsibilities. She specialized in critical care nursing while in the Army. She is the General Secretary for Infusion Nursing Society India, the US affiliate chapter. Colonel Sharma has won many awards, and we are really looking forward to listening to her because this is something very interesting, the equity-based nursing. We talk about it, but we really don't know how to go about doing this. So the more we talk about this and the more we have sessions on this, I think we'll become experts in actually going about doing real-time equity-based nursing. Over to you, Colonel Binu Sharma.
Thank you, Dr. Lallu. Thank you, Kaho, for getting me to talk about this very new or innovative discussion. In fact, listening to the panel discussion a little while ago. And
can you make it full screen, please? Can you make it full screen?
Yeah.
Yeah, done. Go ahead. Yeah.
So I was just listening to the panel members and I listened to Dr. Sanjeev Singh saying that nursing rostering takes 30 to 35% of the nursing time. Isn't that amazing? Nursing rostering is taking 30 to 35% time. 30-40% time is going in coordination of services. Another 30% time is going into nursing documentation. Where is the time left for the patient care? With that note, let me just take you through my thoughts on effective rostering. Believe me, rostering is one of the most complex tasks a nurse goes through. Right from when you are a shift leader or a team leader to when you are head nurse of a department or a nurse manager or a nursing head of a hospital, this task has to be done every single day in all the shifts. Yet, most people are unhappy with it. The doctors have a dissatisfaction because their patients did not get the nursing staffing as per the clinical requirement. The nurses are unhappy, they are overburdened, they still think there is staff shortage. The nurse administrator is unhappy because despite everything, she gave a lot of staffing, yet everybody is unhappy. The hospital administrators, the CEOs, the medical directors are surprised. We have given 300, 400, 500 nurses. Where are these nurses? Why are they not available? So let me start with that. Achieving quality through NABH or nursing excellence. The nursing equity word had come into play in the 4th edition of NABH, and in care of patient standard 6, it clearly mentioned nursing care has to be provided to patients in consonance with clinical protocols. And if you have to achieve excellence, which is in the 5th edition, you need to probably practice equity-based nursing rosters. In the nursing excellence, nursing care of patients, standard 4 and 6 also says the same thing. Assignment of patient is based or shall be based on patient needs, and patient's condition and nursing competency shall be considered for staff assignment. So the equity-based rostering is a proven strategy to optimize patient care. As I said, rostering is a complex issue, the most difficult task to achieve. Matching the right nurse to the right patient at the right time, we all wish to do, but we are all many a times unable to achieve because we do not have a ready reckoner tool which can enable this without adding the burden of an additional work to the nurses, to the shift leaders, to the in charges or the head nurses. The background patient classification systems actually have been way back since 1960. When we discussed the topic with Ma'am Gracie Mathai, I read through a lot of articles on nursing equity, and I was surprised. It has been talked about. It has been into research, into a lot of paper written on it, but a lot of things were without any consensus or without any standardization. And in today's scenario, when we have increasing health costs, when we have got decreasing nurses satisfaction, when we have got patient dissatisfied with the care, there is lack of communication tools, there are staff shortages at all times in our country. I think Acuity tools can appropriately or best appropriately coordinate staffing and patient needs. And this has come through a couple of studies in 2011, in 2007, and patient classification systems and tools definitely allow nurse managers and leaders to do a predictive need. It is not something which you will only use for budgeting at the end of the quarter or at the end of the year or for next month. It is something which is dynamically changing need of your unit, of your ICU, or of your pediatric ICU, which will tell you that what will you need in the next shift. So you better plan, you get people on call, you pull out people or you pull in people. This is what the Acuity tool gives to all of us. What is nursing workload Acuity tool? Nursing workload tool is a scoring process. It's a very simple process. I will just take you through a small pilot which we had done a few years ago. So it's a scoring process which measures the level of care that is expected to be needed during the next shift to support the patients currently in your unit. If you have 10 patients now, it will give you a number based on their clinical need. What is the number of nurses you need in your next shift? But it will not take into account if you get new admissions or transference into the unit that you will have to cater for separately. Acuity refers to categorization of patients based on the nursing intensity. By that, I mean the nursing requirements of a patient. What we are talking here is completely the nursing interventions, nursing requirements for patients, whether how often the patient needs monitoring, how often the patient needs assessment and reassessment, what are the procedures planned for the patient in the next shift. Is the patient on a BiPAP? Is the patient on a ventilatory support? Is the patient conscious? Is the patient on a muscle relaxant? Is the patient on 10 infusions you need to monitor? Is the patient on vasodilator drugs? Is the patient having restraints? Is the patient irritable, needing more monitoring? Acuity also is defined as the individual patient need for patient care, the level of care which can be informed, the nurse staffing which will come into picture, the nurse to patient assignments, and of course, if you have a EHR, can your document of Acuity scoring, can it sync in with your electronic medical record? Because as I said, we do not wish to burden the nurses with another document to do. Again, I heard in the previous panel, so much of talk about electronic medical record. Again, I'll quote Dr. Sanjeev Singh, who said, if the medical record is designed to simplify the life of doctors and nurses and other caregivers, it is fantastic. If it is robust, it is defined, it is realized the way it has been demanded by the caregivers, then it adds value. So if your Acuity tools can sync in, can give you the rostering requirement in your EHR itself, can your HR software sync into the hospital information system, that will be an ideal way to go about it. Acuity scores measures the future workload. As I said, at the start of a shift, the nurses can use the nursing workload score to determine what will be the time required for each patient care based on their present clinical requirement or present clinical acuity status. Of course, it is not a measure of severity of the patient's condition. Does the patient need an hourly RALS tube aspiration? Does the patient need a colostomy care? Is the patient having a tracheostomy? Is the suction needed every 15 minutes? Each of the activity on the patient requires nursing time. And our well-trained, competent nurses very well know how much time is usually required for each of these nursing interventions. Hence, the total time planned for a patient for all of these activities can be put on the score chart. How is nursing workflow affected? The nursing workload Acuity tool does not add a new task for an ideal Acuity-based tool. It should just be a simple tool. I will tell you how we can choose a tool. Nurses will continue to provide the same care. The only thing somebody needs to do at the end of the shift is looking at what nursing interventions or nursing care requirements are there for each of the patient in that particular unit. It cannot be done for the entire 100 patients in a hospital at one go. It is a unit-based activity, a ICU, a pediatric ICU, a neonatal ICU, etc. Aside from real-time documentation, there is nothing else a nurse needs to manage over and above her workload. Nursing workload scores allow the nurse leaders to make sure that patients are spread evenly between the team. If you've got 10 ventilator patients in an intensive care unit, you cannot give all of them to a single staff. So you need to spread evenly so that the patient care is not compromised, and identify unusual patient care need that may require a different level of staffing. For example, a patient is undergoing an emergency hemodialysis in the intensive care unit. His needs become additional at that time. This is something I am just showing a pilot about 4 or 5 years ago. We conducted a pilot study in 3 of our Columbia Asia hospitals, 2 hospitals in Bangalore and 1 hospital in North region in Gurgaon. And we did a pilot. We designed a nursing Acuity scoring system, and we got all our charge nurses to be oriented about it. We made a standard operating procedure. We made some guidelines. We made a ready reckoner sheet, which was formula driven. So here we put in, and we took ICUs because we had more dissatisfaction for our ICU, between our ICU nurses and ICU doctors, whether we are giving the right staffing, because our ICUs were small. So we chose one big ICU, a 40-bedded, and 2 other ICUs, which were 10-bedded ICUs. So activities are put on extreme one side. Basic activities, these are ventilator needs, whether patient is on BiPAP, is the patient on restraint, is the patient going to have any planned procedures during the shift, and all the patients are put on the sheet. So you put patient 1, patient 2, patient 3, patient 4. The sheet is formula driven. What you see on the summary sheet is automatically calculated, and it is thrown to the team leader or the charge nurse of the department, and it tells you what was your deficit, or how many patients had 1:1 ratio, how many patients had 1:2 ratio, how many patients were taken care by 1:3 ratios, how many nurses you had to get in from other departments. Although there are many other factors over and above these, but these were things which we had put in place. And if you see the summary sheet, how do you score? So here you see your staff deficit. So we were in for some surprises where we thought we have adequate staff in a hospital ICU. We found that we had a lot of times deficit, because based on the clinical acuity of the patients, our staffing was inadequate. A patient needed more time. Patient was on IABP. He really needed more time, and the nursing time was going into many other things. A patient needed to be moved for a CT scan or a MRI with ventilator, infusion pumps. So we were able to get a evidence-based data that this is how we performed in the last week, and this is what. So we were able to scale up our our nursing hiring, our manpower corrections. And this document was good enough to justify to everybody, the nurse leader or administrators, to the hospital leaders, that why do you need additional staffing for safe patient care, and so that we can get better outcomes. So the nursing documentation, how does it drive the score? The document that patient needs based the intensity of the monitoring required. Documentation appears in the areas. So these are some of the things, that what activities happened and why we needed so many nurses for a particular intensive care, although we had only 5 patients versus another ICU where you had 10 patients, because of the clinical acuity. There are a couple of tools, couple of documents, reference documents available on net. And this was another one where you would go by the category, whether it's a category 1 to category 5, from a minimal care to one-on-one observation or care in an intensive care unit. And this I found on the net. There are different kind of patient care modules available on this. So in the descriptive one, the nurse chooses the category that best describes the patient, whether it's a category 1 patient or a category 5. In the checklist style, the nurse checks the activity level for each patient, and in the time standard method, in which the charge nurse assigns time based on various activities. For example, vital parameters will take 5 minutes, or a patient bedside bath will need 20 minutes. So these are a few different examples. There are some considerations required when you're designing an Acuity tool. For patient need, what is the length of stay, what is the status of the patient, what are the activities of daily living, what is the need for transportation for the patient, what is the age profile of the patient. For the nursing characteristics, what is her experience, what is her competency level, is she trained well in BLS, ACLS, in handling ventilator patients, and what is the total number of staff available in the department. And for the unit, there are a few factors which are in terms of workflow, the design of the ward, that she has to walk for a long distance, etc. So purposes are all of these, that we need to give safe and efficient patient care based on an evidence-based approach. We need to have a right skill mix. We need to also provide data for budgeting, for staffing, for getting additional staff. It definitely enhances staff satisfaction, patient care outcomes, and doctor satisfaction. We have only 3 pillars in the hospital: doctor, patient, and staff. All of 3 are taken care if you were to execute the tool really well. And here the nurse-patient ratios can be calculated, hours per day method. This was the one, category 1 to category 5, various activities, scoring method, time method, you can choose. Active clinical and operational outcomes linked to Acuity-based staffing decreases mortality, decreases adverse outcomes, decreases length of stay, maximizes patient and nursing outcomes, improves operational outcomes, improves nurse and patient satisfaction, improves financial outcome, sentinel events are reduced, enhances image of the organization, and it is an evidence-based approach. There is nothing hypothetical in this. And optimal staffing is linked to clinical and organizational excellence, which all of you are looking at. Acuity-based staffing is not just a way to achieve better patient outcomes, but also demonstrate the significant value nursing contributes to patient care. Rigorous evidence in emerging to support Acuity-based staffing is a way to provide high-quality nursing care while managing low cost or while making it financially viable. Ownership, only nurse leaders, no one else. So guys who are all nurses in the group, it's your ownership. Choose the right tool, which is easy to implement, less time taken, less effort required for implementation, minimal additional workload, and it fits seamlessly into your workflow, whether it is electronic record or whether it is manual. Thank you very much. Interesting topic given to me.
Oh, that was brilliant, Colonel Binu Sharma. Very, very interesting talk. And I think a very complex topic, you made it very simple. Let me tell you, I've understood the entire aspect of acuity-based nursing. And kudos to you. I'm sure all our participants are full of, appreciation to the talk. And thank you very much for
Thank you very
spending
much.
time.